Hello everyone. Today we are going to talk about odontogenic infections from oral surgery, and the content is taken from Mosby. So if you want to have a reference, you can go through Mosby. Now let's begin. Okay, let's just try to get the pen working. Okay. So now let us talk about odontogenic infections. The microbiology of odontogenic infections represents the flora of the head and neck, mouth, teeth, and gingiva. So the microbiology consists of the flora of the head, neck, mouth, teeth, and gingiva. These infections are polymicrobial. The most common organisms are aerobic gram-positive cocci, anaerobic gram-positive cocci, and anaerobic gram-negative rods. So, the most common are aerobic gram-positive cocci, and then anaerobic gram-positive cocci, and then anaerobic gram-negative rods. Okay, so here you can see these are the microorganisms causing odontogenic infections. Aerobic gram-positive cocci, 85 streptococcus species, 90 of gram-positive cocci, followed by staphylococcus. So this is how the chart is. So it's first aerobic gram-positive cocci, followed by anaerobic gram-positive cocci, followed by gram-negative rods. Organism. The pathologic mechanism by which these complex infections develop has been well described. The highly virulent aerobic streptococcus species initiate the infectious process after inoculation into deep tissues. Now, there are a lot of microorganisms in our mouth, but we don't get diseases, right? It only happens when virulent species inoculate into deeper tissues or there's infection and such things. So what happens when streptococcus goes into deep tissues? It results in cellulitis, followed by proliferation of anaerobic organisms. The aerobic organisms consume oxygen, making the microenvironment favorable for anaerobes. So here what happens, aerobes consume oxygen. So now there is no oxygen much. So it is a favorable environment for the anaerobes. Okay. Now let's go through each page. So mainly odontogenic infections, what happens, the infection-causing organisms are usually aerobic gram-positive cocci, followed by anaerobic gram-positive cocci, followed by anaerobic gram-negative rods. Streptococcus goes into deeper tissues, inoculates into deeper tissues, leading to cellulitis, where aerobes consume the oxygen and makes it oxygen-deprived environment, which is favorable for anaerobes to further infect. Now coming to progression. The natural history of the progression of odontogenic infections relates to their origin as either pulp necrosis or periapical abscess or periodontal infection. So usually what is the history? So what happens? First, it might develop as a pulp necrosis or an abscess or a periodontal infections. Once deep into the tissues, so once it's infected deep into the tissues, it will follow the path of least resistance. Okay. So wherever I'll go through the diagram where you can see wherever there is least resistance, the infection travels. It may travel through the intramedullary space or perforate through a thin area of bone cortex and directly enter anatomic space. The most common space involved is vestibular space. These often drain spontaneously and result in asymptomatic chronic draining fistula. And the most common space involved, where it's least resistance, is vestibular space. Okay, and this will often drain spontaneously and result in asymptomatic chronic draining fistula. Okay, now talking about fascial spaces. Facial spaces involved in odontogenic infections commonly include vestibular, buccal, canine, sublingual, submandibular, submental, masticator, and lateral pharyngeal spaces. These are referred to as potential spaces because in health there is no space. Abscess formation causes cavities along these anatomical planes. These spaces are contiguous, and as the abscess matures and spreads, more of these spaces will become involved, resulting in increased. So when these spaces are involved, what happens is there will be increased pain, trismus, difficulty and dysphagia, and dysphonia, difficulty to eat, difficulty to talk. Okay, and canine space infections and deep temporal space infections can result in cavernous sinus thrombosis via ophthalmic veins. This is very important. So, now canine space infections and deep temporal space infections can result in cavernous sinus thrombosis via ophthalmic veins. Okay. Lateral pharyngeal infections can transverse the retropharyngeal and prevertebral spaces and spread to mediastinum. All of these infections should be considered life-threatening medical emergencies. Now let me show these two pictures. Let me see if there are more pictures that I can show you. Okay. So here in this picture, as the infection, so let me show you. See here, it's infected, right? As the infection erodes through bone, it expresses itself in a variety of places depending on the thickness of the overlying bone and the relationship of muscle attachments to the site of perforation. The illustration notes 6 possible locations. Okay, and first is buccal space. See, here it can go into the buccal space. It can go into buccal space. Next is palatal abscess. It can see here there is infection, so it can form an abscess. Then sublingual space, it can enter the sublingual space. Or submandibular space. Maxillary sinus. So these are all the places that it can spread through. Buccal space, sublingual, mandibular, palatal, and maxillary sinus and submandibular space. Okay. Now see, this is when there is an infection, it can present as a swelling, and this area will feel hot. This is buccal space. Now, these are the different spaces. This diagram represents the spaces of the ramus of the mandible are bounded by, so this is the mandible, it is bounded by masseter muscle, okay, and then medial pterygoid muscle, all right, and then temporal fascia, . And temporal space is divided into deep and superficial. So this is deep and this is superficial temporal space by temporalis muscle. Okay, so spaces of ramus of mandible are bounded by masseter muscle, medial pterygoid, and temporal fascia and skull. Okay, and this is the lateral pterygoid. Now, submandibular space. So this is submandibular gland, and this is an abscess that's formed in the submandibular space. Submandibular space lies between mylohyoid muscle. This is the mylohyoid muscle and superficial fascia. Okay. Now, how do you treat these infections? Treatment of the odontogenic infections requires adherence to the 6 principles. One is determine the severity of the infection through history and physical examination. So first you take the history of the patient. The history should be specific. It should consist of a chief complaint, determine the time. So when did it really start? What are the circumstances of the onset? What caused it? Duration of the symptoms? Speed of the progression. So first, you take a detailed history, you take the chief complaint and ask questions like when did it start, onset, time, what are the symptoms, and is it critical? Like you don't want to question a person who's going into a medical emergency in a detailed questions, right? So you have to note the critical systemic symptoms. That is, does the person have the dysphagia, dysphonia, trismus, fever, chills, malaise, and numbness of face, headache, meningeal signs, and altered vision? The physical exam should include vital signs to determine evidence of sepsis, airway compromise, probable cause, and specific anatomical space involvement. So physical examination should include the vital signs. So to determine the evidence if there is sepsis or airway obstructions, probable cause, and which anatomical space is involved. So here we studied, right? Here, what did we study? How does it progress? It first starts mainly sometimes just as a pulp necrosis or an abscess, and then later it follows the microbes follow the path of the least resistance and it gets deeper infected. Common spaces are vestibular space, asymptomatic, and it leads to chronic draining fistula. What happens when the potential spaces, that is the vestibular, buccal, canine, sublingual, submandibular, submental, and masticator muscles are involved, and lateral pharyngeal muscles are involved? It can lead to a medical emergency, and the patient might present increased pain, trismus, dysphagia, and dysphonia. Canine space infections and deep temporal space infections via ophthalmic veins can cause cavernous sinus thrombosis, and this is highly dangerous condition. Okay. Now, treatment, the first is you take the history. By that, you can ask the patient, like, when did he first start, he or she started noticing it, onset, and then how severe it is, what are the symptoms, and see for the vital signs. And maybe, we can identify that which anatomical space is involved and is there any medical emergency. Evaluate the state of patient's host defense mechanism. That is, suppose if a patient is severely diabetic, then there's some more chances that, cellulitis, condition like cellulitis needs to be treated right away because the host response won't be really good. The host defense mechanism is compromised in that case. So check for the certain metabolic diseases like malnutrition, obesity, drug use, diabetes, and different conditions. Determine whether patient should be treated by general dentist or a specialist. Some odontogenic infections are life-threatening and require aggressive medical and surgical intervention because that part should be drained, cleaned, dressed, and wound healing really takes time. So mostly it's referred to oral surgeons. And if it's a minor, it can be treated by general dentists, which involves usual minor surgical procedures and commonly used antibiotics. Treating the infection surgically is fundamental in the management of odontogenic infections. Removal of the source of infection and decompression and drainage of purulence are the goals of surgery. Surgical interventions may vary in spectrum from pulpotomy to transfacial incision and drainage of multiple facial spaces. So if it involves multiple facial spaces, they need to be drained. And the main thing is you need to remove the cause and also treat it. Okay, so the removal of the source of infection and decompression and drainage of purulence are the goals of the surgery. All right. Then here we saw how an infection can erode through a bone. Here we see in the mandibular region, there is an infection. It can pass through the buccal space, palatal abscess, sublingual space, submandibular space, maxillary sinus. And this is how an infection can erode through a bone. The goal is to obtain adequate drainage so that the spread of the infection can be brought under control and the offending agent treated either with the extraction or endodontic or periodontal management, depending on what the case is. First thing is you need to stop the spread of the infection and remove the cause. Prior to IND, incision and drainage, a specific specimen for culture and sensitivity should be obtained. So why do you take really culture is, by the with the help of the labs, you'll know which is the organism that's really dominant, and accordingly you can choose the antibiotic to treat it. It can be done under local or general anesthesia depending on the severity of the infection. Usually at least 2 ml of purulent aspirate is adequate and can be obtained with the use of a 5 to 10 ml syringe and an 18 gauge needle. The site of aspiration should be surgically prepped prior to obtaining the sample. Depending on the microbiology lab policy, the specimen should be either be capped with a rubber stopper after removal of any evidence of air in the specimen. Air should not enter the specimen, or it should be immediately placed into an anaerobic specimen, oxygen deprived area, and then sent without delay for the lab processing. Gram stain should be obtained to guide the antibiotic management. So we'll know what are those organisms and what are the antibiotics that needs to be given to that. Okay. Now, here you can see lateral pharyngeal space is located between medial pterygoid muscle on the lateral aspect and superior pharyngeal constrictor on the medial aspect. Now, this is the lateral pharyngeal space. Okay, this is located between medial pterygoid muscle and on the lateral aspect and superior pharyngeal constrictor on the medial aspect. So it is having medial pterygoid on the lateral aspect, and on the medial aspect you have superior pharyngeal constrictor muscle. Okay. Now, in this diagram, mainly we talk about 3 spaces. One is lateral pharyngeal space, medially we have superior constrictor muscle, and laterally you have medial pterygoid. Okay. Now, retropharyngeal space. So this is the retropharyngeal space. Retropharyngeal space is situated between the superior constrictor muscle and alar portion of the prevertebral space. So next we talk about a retropharyngeal space. Retropharyngeal space, you can see it is located between superior constrictor and alar portion of prevertebra. Then we have prevertebral space, which is situated between alar area's anterior portion. So now we are talking about prevertebral space. Prevertebral space is located between alar area and prevertebral fascia. Okay, and prevertebral fascia. So these are the 3 spaces. Now, what are the compromised host defense? Where you need to make sure, because when a host response is not proper, it can lead to a lot of problems. Like if a patient is diabetic or having different kinds of problems, obesity, different diseases, the infection spreads faster. So what are the things that you need to check for? Uremia, alcoholism, malnutrition, severe diabetes, and suppressing diseases like leukemia, lymphoma, tumors. And if the patient is taking any drugs, that is chemotherapeutic drugs and immunosuppressive drugs. Support the patient medically with adequate airway management, hydration, electrolytes, antibiotic management, nutritional considerations, analgesics, pain relievers, and identification of medical comorbidities and their possible role in the infection. Choose and prescribe appropriate antibiotics. The use of antibiotics has its own benefits and risks. Consequently, the determination that there is need must first be established. Generally, if there is evidence of bacterial invasion into underlying tissues that is greater than host defense can resist, then antibiotics should be used. It is important to understand that clinical presentation of such invasion can vary substantially based on previously mentioned host defense capacities. The following criteria have been recommended as indications for antibiotic use. Indications of antibiotic use are rapidly progressive swelling, diffuse swelling, compromised host defense, facial spaces have been involved, pericoronitis is there, and osteomyelitis is there. When do you refer to a specialist? When there is infection that's progressing, difficulty in swallowing, difficulty in breathing, facial spaces are involved, high fever, jaw trismus, toxic appearance, and compromised host defenses. Now coming to odontogenic infections. Bacterial targets. Because the causative bacteria seen in odontogenic infections are highly predictable, routine empirical therapy is acceptable. The choice should be effective against streptococci and oral anaerobes. Penicillin is often the preferred drug if the patient is penicillin allergic. Clindamycin or clarithromycin are good choices. Narrow spectrum antibiotics are preferred over the broad spectrum antibiotics. This has been asked in INBDE. Because they have a lesser chance of altering the normal flora with its associated symptoms and impact on the development of resistant strains. The selected antibiotic should have the lowest incidence of toxicity and side effects. That is, bactericidal agents are preferred than bacteriostatic, particularly in immunocompromised host, and the responsible use must be taken into consideration at the cost of the selected agent. So bactericidal, where you're killing the bacteria, versus bacteriostatic, where you're stopping. So when there is heavy infection, you should make sure that bactericidal agents are given. Now coming to osteomyelitis. Osteomyelitis means inflammation of the medullary portion of the bone. Let me see if I have any diagrams. Okay. So, for example, okay. This is the cortical bone, and this is the cancellous bone. All right. So, medullary portion of the bone, what does that really mean? It means cavity in the tooth containing blood vessels and nerve endings. So, infection, inflammation, and ischemia, where there is lack of oxygen supply, are the mechanisms by which osteomyelitis spreads until surgical and medical interventions can bring the process under control. Only medical and surgical interventions can help get rid of this. The common irritating causes of odontogenic infections and trauma, and the main initiating factor is trauma. They follow a contiguous path. The infection usually begins in the medullary space involving the cancellous bone. So it first starts with the cancellous bone, eventually the cortical bone, periosteum, and soft tissues become involved. Osteomyelitis is relatively rare and is most commonly seen in the mandible than in maxilla. So it's usually seen in mandible. It is mostly common in mandible. Okay. Than in maxilla, secondary to the difference in the blood supply. Hematogenous spread of infection to the bone can result in osteomyelitis. So, when there is infection, spread of infection through blood, can result in this disease. However, this mechanism is rarely seen in the jaw. Patients with host defense suppression are most likely to get osteomyelitis. And the causative organism is similar to that of the odontogenic infections, streptococci, anaerobic cocci, and gram-negative rods. Treatment of osteomyelitis is both medical and surgical. Adequate debridement, use of appropriate antibiotics, and medical assessment to rule out and treat any host factors that may predispose the patient to developing an osteomyelitis all play a part in the proper management of this complex infection. So with that, we complete odontogenic infections. Now let's have a quick review. So here in the odontogenic infections, the first causing organisms is streptococci, followed by anaerobic gram-negative cocci, followed by anaerobic gram-negative rods. So streptococcus inoculates into deep tissues, causes cellulitis. Now, progression, it will first start as a pulp necrosis or an abscess and then inoculate deeper into the tissues, and it follows the path of least resistance. So common space involved is vestibular space. It will lead into asymptomatic chronic draining fistula. So facial spaces, if they are involved, it's very dangerous because the spaces, if they are involved, can lead to medical emergencies. And commonly the spaces involved are vestibular space, buccal space, canine space, sublingual space, submandibular space, submental space, masticator, and lateral pharyngeal spaces. Canine spaces are really important because canine spaces and the deep temporal space infections via the ophthalmic veins can cause cavernous sinus thrombosis. Treatment depends on each patient, how their condition is. First, you take a detailed history and then find out when it started, how it started, what are the symptoms, since how many days are they suffering, and is there any emergency, that is difficulty in talking, breathing, or high fever, trismus, dysphagia, dysphonia needs to be observed, and take a detailed history of the patient's host defense mechanisms, that is if the patient is diabetic or is on chemotherapy or is having any diseases like leukemia, lymphoma, you need to have a clear understanding, and then it can be referred to a specialist. Now, the main thing while treating this infection is remove the cause. Bactericidal drugs are given than bacteriostatic, depending on the host defense mechanism. So in this diagram, you see how there is a mandibular abscess here, which can lead, the infection can spread into these different spaces. Now, once incision and drainage is done, it needs to be, the antibiotics can be given based on what comes in the lab, on like basically what is the causative organisms. And this is the buccal space diagram. These are the different spaces of the ramus of the mandible. They are bounded by masseter, medial pterygoid, lateral pterygoid, and temporal fascia, which is again divided into superficial temporal space and deep temporal space. Here we talk about lateral pharyngeal space, retropharyngeal space, and prevertebral space. Lateral pharyngeal space medially has superior constrictor and laterally medial pterygoid muscle. Retropharyngeal space is in between superior constrictor and alar portion of prevertebra. Prevertebral space is between alar area, anterior portion, and prevertebral fascia. Now we know what are the different compromised host defense. I already spoke about that, and make sure that the patient is given the proper support and antibiotics. Now coming to osteomyelitis, it is inflammation of the medullary portion of the bone. Infection, inflammation, and ischemia can lead to this. Even though this is rare, it can happen and it can spread through the blood. And the organisms causing this is very common, very similar to that of the odontogenic infections, that is streptococci, aerobes, and gram-negative anaerobes. Gram-negative rods. So treatment is both medical and surgical, adequate debridement, use of appropriate antibiotics, and medical assessment to rule out and treat any host factors that may predispose the patient to a developing an osteomyelitis all play a part in proper management of this complex infections. I hope you have understood this class, and if you have any questions, please let me know. Thank you.